declarations of interest, I assume the normal ones, unless there's anything additional. Thank you. Minutes of the previous meeting on the 4th of March, are they okay? Grand, and the extraordinary one on the 1st of April, are they okay as well? Thank you. Is there anything on the action log we're worried about? Be very careful about answering this. I'll take silence to be no, you shouldn't be worried at all, Chair. Thank you. Item 5, Chair's Matters, just a couple of things from me. Can I just remind the board we are in the pre-election period. We've had a curtailed agenda properly because we're not supposed to comment on matters that might be vaguely political. So can we be sensitive of that? And secondly, just to remind you, this is my final formal board meeting. I leave at the end of June and we don't have a formal one in June. So I will enjoy it so much. 6, Chief Executive's report, Chris.
Thank you, Chair. Yes, and congratulations on your last month.
I'll need to think about how I take that.
Yeah, okay. So I'm going to do a quick update now on the national changes to ICB. So we've obviously covered this as a board many times and it's been integral to our meetings for the last year. So where we've got to in the process, we've got to do our 51% reduction, and the requirement was to do it by the 1st of April 2026, so we are behind the timeline. And we are comparable with other ICBs, but there is an expectation from NHS England that we proceed as quickly as possible. Where we got to in our process, we had an extended consultation period which we agreed to board. We agreed that that should particularly focus on updated job descriptions, assignment briefs and tooling. It was to focus on the process of filling of posts and also to share our latest target operating model and hold proactive workshops with our staff to get feedback on the target operating model. That consultation period closed on the 24th of April. The board has received the outcomes report and the next steps will be communicated outwards after a pre-election period. So that's the next steps. In terms of the financial position, we finished the year as expected and reported to board with a year-end deficit of 48.9 million, so that's year 25-26. And we're just obviously into year 26-27 where we are forecasting to be on plan. At the start of the year, we submitted a balanced plan to NHS England, and that's been through due process, and that's the plan we'll be working to as a board for the rest of the year. We'll report in the normal way. In terms of planning and priorities for 26-27, there'll also be an annual assessment for ICBs, which is new again in 26-27 as well. But in terms of our future role going forward, the sort of things we'll be assessed on in our plans is outpatient transformation. There's a big expectation, particularly in the reduction of follow-up outpatients. Reducing hospital bed days for high-risk cohort, again, that's something we work on currently, but something we wish to work further on. Schedule and access reform for urgent care, technology-enabled products and improvements, developing the NHS app, payment reform, which means moving away from sort of block arrangements and payment by results arrangements to more outcome-based arrangements, quality and capability building and a focus on it. So they're the key things that the expectation as we go through our planning process. We submitted our planning last month to NHS England, and there's a further return that's due on May the 15th, which will further clarify how we'll approach the strategic commissioning ambitions I've just been through. In terms of our integrated care partnership board, so this is the board that's chaired by our mayor. It met on the 24th of March, and it was just focused on the bold ambition to support the development of early years, particularly 0 to 5-year-olds, making sure school ready. That's the key objective going forward, and obviously with the objective from the Mayoral Combined Authority about South Yorkshire being the healthiest region in the country as well. That's obviously the ambition that we'll work through. We are looking at potentially that board as we move through, and to particularly give it a prevention focus, and as if the arrangements are developed, we'll communicate that to this board. But we're looking to certainly strengthen our links with the Mayoral Combined Authority in terms of strategic planning. As part of that, South Yorkshire has been selected as one of two areas. So South Yorkshire and Greater Manchester have been picked as areas where the chair of the ICB will also be the Health Commissioner. That's a role that will report directly to the Mayor. People ask the question, how will it work? Well, we're going to sort of prove concept and work through, so it's quite difficult to answer that question at the moment, but undoubtedly we'll marry up the mayor will provide authority in the ICB strategically and operationally. So that's certainly something we'll work on and communicate to the board as we go through. Neighbourhood health centres. So we've had capital allocations which we can communicate in the formal finance report for neighbourhood health centres. Again, what we received is an allocation rather than a guidance on how that will work. When you look at the national guidance, the guidance talks about neighbourhoods having 8 till 8, 6-day-a-week neighbourhood health centres. We need to come up with a South Yorkshire approach to where those health centres will go and how they'll operate. That's something we'll have to engage very closely with partners on to understand where we want to target those resources to and where we look in terms of our wider health and care, social value as well. So we've got the allocations over the next 4 years, I think, isn't it, the allocation, which is quite quick for NHS estates allocations. So we'll need to engage with partners as the next step to understand the art of the possible and where we're going to position those neighbourhood health centres. Industrial action, so Dr. Crichton briefed last time, but we're still seeing ongoing industrial action from the BMA. There doesn't seem to be a resolution in sight currently, so our planning assumption is it will continue for a length of more of a longer period than it is currently, and we'll just wait for national advice on that. There's also potential industrial action from general practice as well and GPs, so that's something we'll keep a close eye on as well. In terms of board changes, so I've been appointed as the Chief Executive. The next step is there's adverts currently in process for the Health Commissioner, as just talked about, stroke ICB Chair. Lee has announced his retirement at the end of June, so we've got an advert out going for Chief Finance Officer, and there'll be a process for non-executive members as well late in the next few months. So quite a lot of changes on the board, and I think we're going to move to a new board model. The intention is from the 1st of July in terms of governance. We've talked about it previously, so in terms of partner members and executive members, there'll be the review will be completed for that membership. NHS staff survey results, our response rate was 67%, which was excellent. The staff survey result is as expected. It's been a difficult year. We're in a period of organisational change. I'd say we were comparable to other ICBs, but obviously we have seen a drop in most indicators because of the organisational change process we're in. But in terms of the report, obviously members can see that in more detail and work through. But what I would say is that it will be really important to use that staff survey to build on the new organisation when we move to our new organisational form from July. Update on vaccinations. So from the 1st of April, the eligibility criteria for RSV has expanded to include people 80 and over, and also residents in care homes. So that's something we've implemented. And in addition, South Yorkshire continues to ask older people and those with weakened immune system to book their COVID vaccination as well. Because it's all year round COVID. It's still around in the background. It's not getting headlines like it has done, but it's still something we'd encourage people to get vaccination for. I don't normally go through the place updates because we normally have place reports on the agenda, but as we move to our new way of working, we won't be having the bespoke place reports. So just pick up a couple of highlights from our places. So in Sheffield, it's the glucose control in labour with diabetes trial, and that's being funded by the National Institute of Health and Research. So it'll be interesting to see if we can get some reports back on that. Hopefully that'll be a success. In Doncaster, we're looking at the Waterdale Centre. So this is Doncaster's version of Health on the High Street, particularly it's Rotherham, Doncaster and South Humber Mental Health Foundation Trust. Looking to put some mental health services into the city centre, but it also be a neighbourhood centre. There's something, I know Anthony's place director, something particularly could be looked at our neighbourhood approach in Doncaster in terms of the Waterdale Centre. In Rotherham, Barnsley and Rotherham hospitals work closely together already, but they're particularly working closely on haematology service across both trusts. And in Barnsley, the latest outpatient service is moving to the Alhambra Shopping Centre, again as part of Barnsley's trailblazing Health on the High Street approach, which they've won many awards for, which we've heard about many times. Okay, So in terms of the last one, the NHS South Yorkshire, we recognise at the HSJ Health Service Journal Partnership Awards, and the ICB won the Healthcare Infrastructure Project of the Year of South Yorkshire Primary Care Capital Programme, which we built, I can't remember the exact number, but it's probably 7 or 8 new general practices across South Yorkshire. We were one of only 2 areas picked in the country, and now those health centres are now mostly coming to fruition now, so hopefully patients will see the benefit of those centres. So they're the highlights, Chair.
David?
So it didn't make the highlight, but if I could just add that the tobacco and vapes bill became law last week, a significant piece of public health legislation. We're the first time we have a smoke-free generation, so anybody born after the 1st of January 2009, it will be illegal to sell them tobacco or vapes. We previously brought to board about the Ash Ambition pledge to reduce by 5% smoking rates. They now got a new pledge to be less than 1% by 2040, and I look to potentially bring something back to the board for us to commit to. But I just think we should acknowledge this is really, really significant. So thank you for letting me.
No, and it's funny. I remember I read that it passed, and it actually passed without great comment. And I think it's a huge, significant piece of legislation. So very happy it's mentioned here. Thank you, David. Moira.
Thank you. Just following up on the tobacco and vape thing, which is probably more a question for Greg, actually. I mean, it's really good that has been passed. But I have noticed recently going into local shops that suddenly there's these great multicoloured vape advertisements where the tobacco used to be behind.
Yeah.
And it just strikes me as the wrong thing to do, and I don't know whether the bill will actually help to address some of that.
Greg,
partially, not fully. The bill doesn't curtail multinational tobacco companies from selling vapes and multicoloured, etc., which were well known, well acknowledged to focus on children and young people. That's the target market. The bill basically gives the powers to enforce the law. It's now on to law enforcement authorities, including trading standards in South Yorkshire, to basically enforce the law to the limit of its ability, because that's how you prevent uptake of vaping in kids.
Anthony.
A different subject. So, Chris alluded to the neighbourhood health centres. Not to preempt some of the conversation that Emma and Mariana are going to get into later. It is a very busy space around neighbourhood health at the moment, and there's a lot out there in terms of further guidance, for things. We did talk that we might use one of the development sessions of the board to have a particular session on neighbourhood health going forward. So if members are comfortable and would value that, we can put that into.
We do have an informal in June. Can we pick up what that agenda item is through the execs, and that might be an appropriate one. I think there is something that says, can we have a discussion on this, if nothing else, just the state of play, which I'm not wholly aware of. So I'd welcome that. Kath.
Yeah, just a really brief comment, Chair. I think we used to be much better at recognising when there were new national strategies and things being launched, and there's probably just something about us going back and sort of cross-checking some of that, because again, women's health strategy has been relaunched in the last couple of weeks, so how we make sure we've got some of that on our forward planner.
Good point. Chris, thank you. Questions from the public? We've had no advanced questions from the public. Board assurance framework, corporate risk register. Mark, thanks. Please.
Chair. So I'll take the report as read. Would note that the content of the board assurance framework and the risk registers have been subject to consideration across the organisation and through our various governance mechanisms, which is summarised in the paper. It's presented to the board for review and approval. I would note, though, that there is an ongoing process to review the risk registers in the context of organisational change, and also in response to internal audit feedback around finding a more simplified and concise way of reporting risk to the board and engaging around the mitigation of those risks, which is helpful and an objective challenge from our internal auditors, which is always useful. So just to repeat, Chair, this is a request from the board to review and approve the paper that's presented to you.
Thank you. Go on, David.
So I do need to pull one out if I may, because
Please.
the ICB had an assurance meeting with NHS England on its health protection response.
Yes.
And as a result of that, we've added a new risk in regards to our duties to commission a service. We've got a number of actions to take forward. But part of the letter I received was that I'd raised that with the board, so we were cited on it. But at this point, I look to bring a further sort of report and response to the assurance meeting.
Noted, thank you. Any other questions on it? Christine?
Just to note that the risks that are coming out of the organisational change process and business continuity are feeding into this risk register by the transition committee. So.
Okay, and that will be picked up with the transition committee. Thank you. Thank you, Mark, thank you. Agenda item 9, strategic commissioning plan. Emma, Mariana, are you starting, Emma?
I'm starting, thank you. Yeah,
thank you.
So thank you. Yes, so thanks, Chair. So I think just to bring you up to speed, I think you'll remember that our initial strategic commissioning plan was considered by the ICB board in January and then submitted in February. We haven't actually had any feedback from that document as yet, so we're still waiting for that. But we have had some additional guidance that came in beginning of April from Jim Mackey, which outlined a number of key priorities that we need to think about. So obviously, what I've tried to do today is just to summarise some of this in slides. So I'll take the report as read. I'll probably just move on to the slides if that's okay. But I think just to sort of set the context, I think, you know, how do we make sense of this moving forward? Anthony's just talked about the number of things that come out from the centre that have some alignment, but I think there's so many things going on. It's how do we kind of make sense of them as an organisation and make them into something practical. So I think the key focus for us moving forward is how do we get from A to B. We've got a plan, but actually we need to think about some key things, focusing on a small number of things that have the biggest impact. And how do we do that at a time when, you know, we are a different organisation. We need to maintain and improve relationships with our partners, with Simca and with our population. So I think they're just really important things to note as we're moving through the slides. So thank you. So just moving on to the slides then, yeah. So in terms of the expectation, I think we've already talked about this. In terms of the model ICB framework, I think we are now seeing much more as strategic stewards of a system responsible for how healthcare is utilised. So I think in the past, being a good commissioner isn't just about developing good specifications. It's about thinking, how does our population start to utilise the healthcare that we commission? Are we making the best impact? Are we driving value and quality and performance moving forward? So I think we need to really focus on neighbourhood care and prevention, which is key. But actually, how do we do that left shift? We can't do it without sort of ambition, but also resource. How do partners act together as one team? How do we have collective ownership? So we're moving away from being a convener role, but actually the only way we can make this work is by working together, leaning in and understanding that different partners are going to have different roles and responsibilities in the system as we move forward. And how our financial flows, not looking at Lee here, and incentives going to support collaboration, because if the money does not flow, if people cannot see how that is going to happen, then people will not manage that risk. So how are we going to start to have really different risk conversations about how we start to move money around the system? But I think what we can't lose is the strong foundations that we've already got. There's loads of good work going on, things like Health in the High Street in Barnsley and other things. How do we build on those things moving forward? Because I think they have really demonstrated where we can make some huge improvements. So the next slide is just around strategic context. I'm not going to go on with that, but obviously everything we do must be rooted in those 3 shifts. So that has to be our sort of guide. The next slide is just the 8 national priorities. Chris has already referred to them. I think, you know, there's going to be a huge focus on things like outpatient transformation. I think meds management, again, is the area where we spend the second most of our resources in. So again, what we're going to do on that. I think there has to be a real focus on workforce as well. So we talk about workforce in this meeting, but we actually, moving forward, how we deploy our workforce as a system has to be crucial. If there's no more money, then we need to move that workforce into different spaces. So how we're going to make sure that we can use that workforce in out-of-hospital settings to drive productivity and efficiency. How we're going to use NHS, the NHS app and technology, you know, AI, are we going to be able to use that? We're talking about maybe 4 or 5% productivity in terms of some of that technology. So how are we going to bake that in? And again, I talked about payment reform before. So I'm trying to just And we've done some work with system leadership executives, so that's where all of the partners come together to think about what are the things we can do. Firstly, in year one, in terms of stabilisation, so that's the year we're in now, just for everyone's benefit. We're now in that phase, and we need to be restoring financial control. So we strengthen our governance processes. We've now got a really strong turnaround programme, and we've got a real grip on that. But how do we start to shift from technical to allocative efficiency? As I say, what are the programmes we're going to focus on? So outpatient transformation has to be one, but who's going to do that? You know, we're not really going to go around telling providers how they do it, but what we need to be saying is, this is the opportunity that we think exists as a strategic commissioner. How are we going to start working to ensure that in 12 months' time, in 2 years' time, we're going to be able to release that cost? And again, you know, fixed costs in hospitals, how are we going to have that conversation about what does that mean? How can we redeploy that resource elsewhere? How are we going to really start to embed neighbourhood health models? And again, loads of information on this, but you think about how we manage frailty, how we manage children and people. There's going to be lots of things for us to do around secondary prevention. Obviously, we are already a prevention accelerator, or we're going to be. We've got the health and work programme that Christine's going to talk about, but we're going to have to start doing things at scale. So we've talked about opportunities for years around decommissioning procedures of limited value, but we haven't really stuck to that. So again, how are we going to start doing that in a way we know there's huge variation? And we've got a strategic commissioning tool that we have piloted in the ICB. And when you start to look at that, there are huge opportunities about managing variation across the patch. So even if we did that, we would definitely be able to save resources and use that money differently. So I think we need to pay much more attention to those things. So in terms of year one, I think there are things that are already in place. It's very much around technical efficiency. You know, how do we work with our providers around their huge efficiency plans as well? We all know they've got efficiency plans that are probably the largest we've seen in a number of years. So again, how are we going to work with them around that? In terms of the commissioning intentions, sorry, I think that's the next slide. We're on the next slide, yeah. The commissioning intentions, we already pulled those together last year, but again, how are we doing on those as an organisation? We're already sort of, you know, halfway into Q1. You know, we need to make sure that those things are going to start to have an impact on our bottom line, because we set them with a purpose of actually starting to monitor those things. So again, I think we need to bring assurance back to the board in terms of where we're up to, what's on track, what's not on track, just in terms of year one. In year two, I think this is where we start to think about these big transformation programmes. So things like outpatients, things like frailty, things like neighbourhood care, implementation of the modern service frameworks, they're coming in. For those of you who are old enough, you'll remember the national service frameworks. They were very, very good documents, and actually really start to improve care in big areas. So again, there's lots of great things that we can adopt as an organisation moving forward. But again, we need to start thinking about how we do that. Also, in terms of strategic reinvestment, how do we start to say, if we can release money, how do we start to put that into prevention, mental health, digital transformation, estate modernisation, the things that will enable us to be more productive? So I'm not going to repeat these things I've already talked about. We really start to need to think about how we're going to do it, but also how we're going to work with the combined authority as a health commissioner. I mean, really, if we'd been planning maybe 18 months ago, knowing this was coming in, what were the opportunities to work with Simca for some of our back office functions around insights, public health, intelligence? Because again, we need to do things really differently, particularly when we've got a small resource internally. So I think we're going to have to start getting into a different way of working, but it's about describing big changes, transformation programmes that we will lead and set the outcomes for as a strategic commissioner, but how then will our partnerships pick those up in a different way than we have before? And how as a board are we going to hold ourselves accountable? How are we going to assure those programmes and make sure we're going in the right direction? Because you can't have a plan if it's not attached to a financial plan. And I think often we haven't had the two in one place. So I'd like to think that in 3 years' time, sorry, not 5, we've achieved financial balance. We've established mature population health management across South Yorkshire, and more importantly, we've built a collaborative workforce, because this is very much, as I said, if we don't have a collaborative workforce, we're not doing things differently, we're not going to be able to deliver this change in the way that we need to. So in terms of how we take this forward, again, I think there's some critical components for system change. Anchoring the system in a small number of population health management outcomes, using PHM to target the highest area of need. I think there's lots of opportunities to reduce health inequalities and shape that healthcare utilisation, particularly in frailty and complex areas of need. Clarity on what shared success looks like. As we have a different role in this space, I think it's all important that we're all, we're looking at, what is our North Star? I know we talk about these things, but are we all rowing in the same direction? We have to be. We've got to, with the financial challenges that we face, the demographic challenges that we face, and all of the other issues we talk about. We need to redesign our financial flows to support collaboration. So again, in this letter that we've got to do some work for the centre, can we start to discuss the areas we'd like them to support us on in terms of payment reform, creating those conditions for collective delivery, things like year of care for diabetes. There are lots of things we could do differently. Hardwiring place-based leadership, not as we know it. This isn't about creating another layer of scale, but actually it's been a real strength, place-based leadership, places where things happen. So how do we have a South Yorkshire vision that absolutely plays into that place-based space? I think vertical integration is hugely important. We focused a lot on provider collaboration through, the acute fed and through the Children and People's network, but actually a lot of the duplication, as we know, is in those vertical pathways. That isn't about one single organisation, that is about pathways of care being looked at differently. So again, I think, what things could we do once at at South Yorkshire in terms of specialist expertise, but then leveraging that into the 4 places that we still serve. And I think the other thing for me is how do we embed a learning culture? And I'll say this as a place director for Sheffield. There's loads of things that are going on really well in Barnsley. Have I really adopted and learned from them? Probably not. I think our assurance systems have been really heavy and they've not been about peer learning. If you think about how local authorities use peer learning to improve, I think we could do probably more of that. And how do we really start to have those trust-based relationships to enable and sustainable change? And again, I think that will come from the new system leadership, executive arrangements. How are we going to trust each other as partners and leaders in this space? And actually, it's not going to be about win-win. There's going to be lots of times that organisations may lose, but that would be better for the population. And how do we have those really strength-based conversations as we move forward? Finance, again, we've already talked about this, huge financial challenges. We need to ensure our internal finances are continuing healthcare, our meds management and other things that we have direct control over as hugely. We have a really strong plan for those and we put our resource around that, making sure we can deliver that. But actually the opportunities that a strategic multi-year financial plan may offer us, what are they? Have we harnessed them? What else can we do? And again, I keep coming back to governance. How do we make sure that this board is well sighted on all this? And we have a really, I suppose we look at quality, finance, performance and transformation, in one place, and we look at where we can improve month on month. And I've talked about workforce before. Finance slide, I've talked about this before, and I think this is a great example of, we've talked about it before, we've seen this pie chart before, sorry, it's the next slide. Again, where does our plan spend need to be in the future? It's the next slide. Where does our plan spend need to be in the future? If we haven't got anything to aim for, how are we going to get there? So again, I keep coming back to, there's going to be multiple things coming down at us over the next 3 years, but actually, how do we remain really focused on a few things? How do we really start to see that shift? Can we be saying we want our growth to be protected to left shift and prevention? Who knows? These things might be there for us. So in terms of next steps, Mariana will talk to you about the work that we're currently doing, but I guess I just wanted to sort of say to the board, I've said to others, are these the right strategic priorities to shape health utilisation and outcomes over the next 3 years? I think there are loads of opportunities for us to test the emerging population health delivery models in terms of integrated health organisations, the new contract models that exist, moving much towards a more outcome-focused approach with contracts that actually reward quality. Obviously, we've talked about this for years, but we've really got to start, pinning our colours to the mast. And how should the system organise itself to lead and enable delivery of this work effectively? I think OD is going to be key to us. It is internally, and I think it is externally in terms of how we work in that new NHS operating model and how will we measure collective impact and learning beyond delivery and assurance, as I've talked about before. So I think what we're saying in a nutshell is we've got a lot to do. We've got to pick a few areas where we think we're going to have the most impact. We've got to work in a different way with our partners in our new roles in the ICB, and we've really got to keep an eye and focus on the money and productivity and our relationship with our partners as we move forward. And I think that's it from me. I'll just hand over to Mariana just to talk about where we are now.
Not to duplicate anything that Emma said, but we thought it would be helpful just to make sure that the board are cited on the ask of us for mid-May in terms of the additional submission. So Emma referred to the letter and the areas that were identified in that letter in terms of priorities. What the ask of us is this is in addition to kind of supplement the plan we've already submitted, is for us to share back with the centre an understanding of how we plan to develop strategic commissioning, both as an ICB, but also thinking about that in terms of the system and how it develops our ambition around neighbourhood care and health, and that's thinking about things like the opportunities and the appetite we have in terms of taking a population health outcome-based contracting approach and thinking about the new income and contracting arrangements. I think, Anthony, you referred to quite a lot of the guidance that's come in over the last few weeks around neighbourhood health and the opportunities we've got in that space. There is something about setting out our ambition in the submission for mid-May, but doing that in a way that we can build on that in terms of the direction of travel. And then lastly, it's an opportunity for us to actually articulate what type of support we would like to see from the centre, both in terms of financial flows and, you know, what level of flexibility we might like to be looking to test out, but also more broadly, you know, what is it that we would like them to help us with in terms of unblocking some of the challenges we have, which is about enabling us to create the right environment to be able to deliver our strategic commissioning plan. So we have got some work that's underway at the moment. So we've got a kind of a bit of a working draft. We have got, we had a discussion with system leaders last week, which has informed the development of that. And we're looking at input from partners at the moment. So that working draft will iterate and develop over the next week. What we're looking for from board is support from yourselves to be able to finalise that next week. And then I think, Chris, you're looking as to whether or not that could be delegated so that executives can make the final decision in terms of agreeing that before submission to NHS.
Yeah, just to pick that up. So the submission's on the 15th of May. We've obviously signed up as a board our 3-year plan formally, so that's the formal document. This is like an interpretation of your ambitions beyond that, but it isn't sort of nailed on, this is what we're doing in terms of formal governance. So we're trying to give you the frame of it today, but we'll continue to develop for another week as we engage partners and get feedback from others. So what we're saying is if we can get comments and feedback today, we'll then iterate what we've got today for the submission on the 15th and then come back for the next formally meet so we can just describe it together.
Are you ready for questions?
Yeah, that's why I said Greg.
I'll just checking. So thank you. The first question, are they the right strategic priorities? Yes, broadly. Just two very specific points, then one broader point. You know my bugbear on the sort of the high risk cohort, focusing on those people at the top of the triangle. I'm a non-believer that will fundamentally shift outcomes or save money for a million and one statistical reasons. It remains number one on the national set of asks. Yeah, whatever. Second point, procedures of limited clinical value. Having played that game many times over my career, I remain a non-believer that will yield much financial saving. You will lose a lot of clinical support doing it. More broader point, the commissioning intentions feel right. The big macro question is the sustainability of primary and community care. There's a bunch of specific stuff which feels like the right stuff to do, but the big macro question is fundamental sustainability of primary care, particularly in more deprived, lower income communities and the way in which funding formulas work and all that kind of stuff. So Emma, I was struck by your point on growth and the like and how we protect growth and do sort of broad spectrum investments as opposed to narrowly focused schemes, and do so in a pro-equity kind of way. There's a risk, a big risk, that as the regulatory regime tightens, the performance regime tightens, the finance regime tightens, we'll all look inwards and not look at system. And I don't know an easy answer to that one, but those are my thoughts.
That's really helpful. I think targeted investment, I think, is important as well. Yeah.
And I think you're right, Greg. I think the biggest risk we've got at the moment in the NHS is as the performance regime tightens, and it has tightened, both financially and operationally, the equity debate Who are the cohorts we need to help? How do we reach out into communities differently? That looks and feels like it's getting pushed aside, and that's the challenge for all of us, I think. Shahida.
It was just to pick up on the kind of request for support. I mean, I know we've got stuff in here about organisational development through our sort of transition phase and things, but I also think there's something about that kind of OD thinking for the system, because we will say very often, well, we need to do things differently, but we very rarely have that conversation with our system partners. But what does different actually mean then? And I think part of that is an OD space, or a space for reflection and learning with our system partners to say, well, what from your perspectives and our perspective, what does this actually mean? Because I think when we talk about left shift and doing things differently in the future, as a strategic commissioner, what does that actually mean for us? But I think it's creating that space for learning with our system partners. Well, how are we going to actually do it? Because I think sometimes we say it and our intentions are there, but then everybody goes back to what's comfortable. But it's kind of pulling out of that and recognising, well, actually, maybe do we need some OD as collectively as a system to say, well, what does that mean for us then?
So that's what I was saying at SLE, and I think that Chris is picking up, but I think it's going to be chief exec only, and it's going to be an OD programme focused on change, because I think a lot of the work we've done at SLE has been business rather than behaviours, and how do we get into a space where we start to think about, I say it's not about win-win, it's about winning for the population rather than, organisational wins. I think that's where we're going to get into.
Yeah, what we're trying to do is change the subject matter, and what we're trying to do is, rather than the ICB sort of, how can I put it, we tend to present our plans and partners' feedback on them. We want to be very much partners coming up with the plans together and enacting together, because then when you get to delivery phase, it's become a lot easier to go to. And it's a different way of working for South Yorkshire.
Yeah, significantly. So that's why I was thinking about that request back to national, or the centre around support, a specific ask around, well, actually we need some, targeted investment in OD that enable us to do things differently and empower the system in a different way, which it's not already had before.
Christine.
Thank you, Chair, and thanks for that point, Shahida, because mine's kind of similar. I mean, whilst I welcome the focus on workforce, I think what I would really appreciate is that we think about the context in which we articulate that in that strategic plan, given our changing role. I would also remind colleagues that we do have a working together strategy and pathway that was developed by the people function, whilst we have the workforce system responsibility. So you've referenced working together. I think that's probably really quite a helpful infrastructure document to be able to take forward. So I think there's something in the framing of it that tries to articulate what is our role in that space going forward compared to what it has been currently.
Katie.
So really excellent piece of work, I think, and really captures the challenges that we've got. I think the strategic priorities really align to the work that probably all four places are talking about, to different degrees of, I hate this word, specificity. There we go, it came out right. Thank you. Yeah, I thought it wasn't going to work there for a minute. But I also wonder, Emma, and I think this is part of the conversation we're already having, whether we should be saying to our emerging partnerships, because everyone is aware and working through how are those provider partnerships going to work differently with the ICBs in the future. It might be an opportunity to ask them how they would respond to this, so kind of stepping into more of that strategic commissioning role, and it probably links to some of what you were saying, Anthony. And then the other thing that I think will be important as we move through some of this is that as our thinking gets clearer as an ICB, I certainly know I get asked questions about what's the ICB view on how they want us to establish provider partnerships? So do they have a view? I know I am ICB as well, but with my joint hat on. And I said, well, we do, but we're not quite there yet. But I just wonder if this piece of work begins that conversation about, from an ICB strategic commissioning perspective, what do we want those partnerships to start to form as? And I guess what we're going to be asking them to do is to deliver some of the things that are in this strategy. So I just think it's a really useful way of engaging in that conversation.
I've got Kevin, then I've got Anthony, then I've got Lou. Kevin.
Thanks, Chair. What Katie said. Effectively. I really do like the plan. I particularly like the 3-year phased recovery and sustainability thing. I think when we're in the thick of the weeds in the next 2 or 3 years, we need to remind ourselves of what we're trying to achieve here. Like Katie, I think very much the emerging new ways of working at place need to come to the fore here and start to shape how this will be delivered for all the reasons that Katie has indicated as well as Emma. I think there is something about our own capacity here though, because we've just got to be a little bit more realistic about what we can achieve, particularly during the year of transition. So that's why I'm particularly like let's pick fewer things that we can do well. And that will mean starting on a journey of some of the transformation projects, which might only start to bear fruit in years 2 or 3, but we need to start them anyway. So I like the idea of going back to our places and saying, well, you know, we need to have a blend here, don't we, of what is nationally dictated. For one, I do like outpatient transformation. I think that unlocks all sorts of things. I do worry about the national dictates down to introducing more advice and guidance. That's not transformation, it's more tactical stuff. But there is a way that we can set out our ambition to have no more outpatients in the hospital environment, for example, and work completely differently, shift those resources around. So I for one would want to pick a few national ones that are more pertinent to us, very much have the place nuance on how to deliver that. But going back to Greg's point about, well, what's as important to us then? So we're going to get suffocated, aren't we, by the things we're meant to do nationally, all fairly laudable, and we might miss some of the things that working with our places are actually more as important for us. So I would challenge the places to start identifying that and recognise that we'll have a mix of things that we need to do, but let's keep it to a lower number of things we're going to do, but do them really well and show the benefits.
I'm sure that's right. Anthony, then I've got Lee.
Yeah, so what Katie and Kevin said. Just going back on a couple of points though, I do think that this is excellent and really well timed as we go through the sort of changes that we're doing as an ICB and system. Why wouldn't we be setting it in this context? So it's really well done on that front. I think there's a job for us to do, Shahida, in our messages upwards, and I'm using my words carefully here. I think there's some mixed thinking around neighbourhood health and what it's there for, and it's all things to all men and women. So on one hand, I think it's very much as we would see neighbourhood health getting in around our residents, wrapping around our organisations around them. On the other hand, it better deliver X, Y and Z as a result of it. We have an opportunity coming up, Chris, don't we, of a national visit on neighbourhood health to get some of those messages across, because I agree with Greg, if we don't put primary and community care right at the forefront of this, it fails. But we're trying to do that at a time of potential collective action in primary care, etc. So I think there's a real opportunity for us to get some messages upwards about what it is we're trying to deliver, and a lot more joined up thinking, if I'm honest, about what we're being asked to do.
Lee and then Greg.
I've been thinking a bit about the strategic commission plan in the context of the recent Health Foundation report just on healthy life expectancy, really, and I think there is something for us. So the Health Foundation report was published on the 26th of April, and just trying to report this kind of bit of a plummet in healthy life expectancy, particularly linked into more deprived areas, which our populations represent. I think it'd be really interesting for us as we work through how do we work really well with the Mayor of the Combined Authority with that jointly appointed chair commissioner role. There's that axis about socially determined disease and facing into that. But we had a really helpful conversation, I think, at System Leadership Executive about how we needed some of our provider thinking to change around. We didn't have an advanced foundation trust applicant on the patch, but we recognised that we're going to have to hold contracts that are much broader than those which we currently hold. And we were thinking about just what the mental health investment standard had forced us to do, to have the thinking about good versus bad spend for the health pound in South Yorkshire. And we were just thinking about how that mental health investment standard forced us to think about more anticipatory and proactive care And now we could get into the space of, for unscheduled care and chronic disease more broadly, how did we think about good spend in that sort of proactive and anticipatory care spend, and the bad spend candidly being decompensating medical patients in the elective pathway? How did we ensure really high value clinical interactions? I'm a bit nervous just about staring at follow-up outpatients as though they're axiomatically a bad thing. There's blooming good follow-up outpatients, so how do we think slightly differently about that? We also talk about children and young people, so I think there's something about how we work with the Mayor and the four authorities quite differently about socially determined disease, and then there's how we work quite differently into provision about thinking through our programmes of spend and good versus bad spend and the efficacy of the money we do spend, and it's a lot, 4 billion quid in the South Yorkshire system, so it's less about needing more but redeploying it.
Correct.
Too quick, on that report, the Health Foundation report, I've done a fairly detailed analysis on why what's happening is happening. I will not repeat it in a public meeting in the middle of an election period. On the what's to do about it, one of Anna Hartley's registrars has done an amazing report. I've trailed it here before on the sort of the how to do, what to do next. Just one I was going to say, picking up on Anthony's point on the sort of the thinking at national level on neighbourhood health centres, health, whatever. Yes, 100%, and I fully agree with the sort of the managing upwards and taking the ground and seeing neighbourhood health in the context of everything else that's going across multiple other government departments on neighbourhoods, and that's the for me a real win, as well as the sustainability of primary community care. So.
Yeah, and just to follow up, there's something about staying true to the path, isn't there? Because if we do make the shift, there will be a huge unmet need that is generated in the first instance, so any of these changes will not happen in a 12-month period. It will take 3 years before you get through the hump. And I know that's bleeding obvious, but at times that we're in at the moment, in terms of that initial knee-jerk reaction, there's something about taking this, following it through with intent, I guess.
Sinead.
In the context of everything that's just been said, I mean, if we look at the pie charts, the financial pie charts that we had, and we're looking at the planned spend for 28-29, the question in my mind, and it kind of links back to the stuff that Greg was saying, how do we balance that pie chart out in a way that, you know, does all the neighbourhood health, because the neighbourhood health stuff is going to happen in community health services, it's going to happen in primary care, it's not going to happen in acute trust. So for me, there's something about, you know, Sarah's point about, well, if we're going to stay on this path, we are going to go through a period of system transition that is going to shift the balance of that pie chart in very, very different ways. And I suppose it goes back to that system OD conversation about how do we draw some of this out of acute services to say, actually, the way that we will be commissioning some of our services is going to be different because we need it to be different, but we need to do that collectively with you. And I think we also need to recognise the risks around that, because there will be resistance, because there will be people who want to do things the way they've always done things because it's comfortable to do it that way. But I think the thing that worries me is that when you look at that planned spend, I'm not saying we can, you know, need to fundamentally change that, I don't know, we might do, but can we do the things that we aspire to do when we are financially constrained in the way that it's presented to us in that pie chart? I'm not saying we can't, I'm just saying it's going to take a bit of time, but I just kind of want to flag that up, that what we say we want to do and what the finances say we can do might not always match.
Well, I think that is the million-dollar question, isn't it? So I think, you know, we've got to be brave, we've got to be courageous. You know, there's business cases coming through all the time. David's chairing the privatisation panel now. Investors say, you know, we're doing some great work in Sheffield on ADHD pathway, which, you know, if that's going to save us a lot of money. We've got to be brave. We can't get locked into this. If we get locked into what we spend our money on currently, it's going to be really tricky, like you say. It's going to be difficult and have some very difficult conversations. But again, the NHS planning is very NHS planning, but it's the wider determinants. It's the non-medical stuff, it's the children and people stuff we talked about. Again, it's going to have an impact. So again, those place partnership, however they exist, as everyone said, are going to be hugely important. But I do think we need to start modelling scenarios through of, if we were to look at year of care for diabetes, for instance, that's looking at patient pathway from end to end. It's not looking at organisations. That we've got to start thinking about people rather than organisations and how we would want to spend that money on a capitation based on, you know, looking at healthcare utilisation as opposed to saying we're going to contract with X for X amount of procedures. Is that going to really improve the health of communities? Is it going to target the deprivation? And that's where the Health Commissioner Simca role, I think, will be helpful in terms of, you know, how do we get that support? Can't really say too much, obviously, that, you know, how do you start to leverage some of that support to do things differently? But I think we've got to be brave and test things out.
Really helpful discussion, bit of process. So the next response to this in mid-May will go off with the execs. I think it needs to come back, because the real issue for the board is the one you asked, how do we make it happen
Exactly.
in the current environment? I think that's the discussion the board needs to get around.
So just the process, Chair, if I can. So
Please.
we'll take all the feedback from today. We'll take some feedback from partners. Partners will send us examples of things they'd like to do to make. When I say partners, I mean local authorities, trusts, general practice to go through. We'll send in BCSEs on there as well. So.
Just one teeny tiny thing. I'm so sorry. I know you mentioned that local authority, but will there be any patient voice in this? Because we've not. I know that not in the.
So this isn't our formal plan. So we've submitted our final 3-year plan. This is about ambitions for us as an organisation. So what I did do, it's not to get to a formal plan. We go through all that process to do the full involvement piece. But this is something we're given a couple of weeks to come up with a return to NHS England for. So it's a funny process, isn't it? It's out of normal process, but it's a good chance for us to really show ambition as South Yorkshire.
But
So
the whole thing will have to be predicated on as we move into how we start consulting people. Like we said, it's not in the town cells we can't do it. When we start getting those big change programs, that'll be key, won't it?
I suppose it's really important for the board in terms of governance. This is about showing ambition, but it will then inform our formal plans. We should go through formal governance. This is looser governance, isn't it?
So I think that's helpful. Board, I think are comfortable. Can we see what goes off? I'm not approve it, but see it. Secondly, I think then we need a discussion on the big issues, which is how do we do it? Okay. Thank you very much. Thank you. Liz, it was great. Item 10, IPR. Sarah, you take us through this?
Yeah, I'll take
At least
that.
initially.
Thanks.
Thank you.
So, thanks. I'll do the operational issues, then David and Kathy for clinical, and then Christine for the workforce. Just take the report as read then. So briefly, in terms of the 4-hour standards, the challenge was to get to 78% of people treated within 4 hours in March. We got to 77.9%. We were 0.1% off hitting the national target, which was a shame. But actually what it does show is the ambition in our trusts and the ability to, when they focused on this, we've seen a significant improvement in 4-hour standards from January and February up to the March. So really positive in terms of that. In terms of ambulances, we continue to perform really well, and you can see that in the report, and say that all of our handovers are below 15 minutes or as a system. So really positive in the urgent care space, recognising the challenge going forward into next year though. And actually, we've only ever, when you look at the data, seen a 3% improvement month-on-month, year-on-year. So a significant challenge next year in terms of urgent care and the changes needed. In terms of the elective space then, we finished the year on something like 1.6% of our patients above 52 weeks. The national ask was 1%. It has fallen off the national agenda. The very specific issues are in Doncaster around trauma and orthopaedics and ENT, which we're working with them on in terms of that recovery plan. In terms of the elective position against RTT and the 65% target, we expect to hit that in March, excluding STH. So again, the sprints, the additional funding that's been made available has shown improvements in our position into that March position, but that does exclude STH. In terms of cancer then, again, we all know we've struggled in the cancer space, but there are some green shoots in this report. If you look our FDS, so notifying patients within 28 days whether they do or don't have cancer, we're up at 83%, which is probably the highest we've been. 62 days for the system is still down at 61.3%, and it's still does not compare favourably with other systems and other providers. So we still have significant challenge predominantly in STH, although we have seen a little bit of a wobble in some of our other trusts. But what I would point out from the report is the improvement in the 31-day standards for STH. So they did treat, I want to say 89% of their patients within 31 days, which is a real positive and a step change. And they have also reduced their backlog by about 80 patients, which in cancer numbers is a significant amount. So if you add all of that up, you would hope and you'd expect to see improved performance in March. They won't hit their March trajectory, and they have set themselves an extremely challenging trajectory going into 26-27s, recognising that they do need to focus on this. So that recognition is there within the trust. In terms of mental health, again, good news, we were down to 9 outpatient out of area placements by February. So again, massive effort gone in there. And we have had volatility and that will continue, but certainly in this report we've seen a reduction in the numbers. The one thing I would like to point out, and we haven't documented in the report, but we should have, that is around learning difficulties for autistic patients and those with ADHD. We have been put on enhanced monitoring for the number of inpatients that we have in beds that have got autism or ADHD. Kathy and I are currently working through the recovery plan, and enhanced recovery means 2 meetings a year. So let's put this in context in terms of what the ask is, but we're not where we need to be, and I think we do all think we've got too many patients with that in inpatient beds. So we do need to further develop that report and that action plan. And as I say, Kathy and I have been working closely on how we recover the position.
Because presumably my immediate reaction, and I'm an utter ignoramus, I'll plead guilty, is that the idea of people being in for that reason feels inherently wrong.
They've not just in for that reason,
No, I get
they have got
other issues.
Yeah.
And that might need some coding issues kind of stuff.
There's probably something around prioritisation of commissioning of services, so I think it feeds into our commissioning intentions, and I think that bit that Emma described with the winners and losers bit, it differs in
place, and we have different arrangements in place, and we have different. We need to stop, look at what we commission. Are we getting best value? Because dreadful for the patient, not a cheap delivery model in terms of care. And actually, is this really what we want for South Yorkshire residents? So there is a not short-term fix, but there is opportunity to do more for these patients there in that space. So I'll stop there on the operational ones and take any questions.
The only thing I was going to add was I thought the numbers on out of area treatments, it's real progress compared to where we were. And I think we underestimate how much trauma they cause, those out of area treatments. And I think this is, it's generally cost effective, but real quality of care. Relatives having to travel to, I talked to one, Maidstone, because there's some, that's awful. So that's real progress which we should actually enjoy and celebrate.
It's not a specific question about any of the operational targets, but it's about relating to our shifting performance focus as a board. Because we're shifting, aren't we, from here on in to be the overseers of the community into the delivery of the contract. Will the reports to us change going forward then? What's the focus going to be?
So we have had a lot of discussion about that. Some of these clearly are contractual, and so we will need to continue to see that, but in that contractual space. But the NOF targets, so the oversight framework has, I don't think it's formally been released, but we will be judged as an ICB on a range of indicators, and we're currently working through how this report will transition over Q1, ready for Q2, to look at how the ICB will be judged as opposed to how the system will be judged.
So I'm guessing going forward, the lens of review will not be on standard per se, it will be on the provider delivering the standards we've contracted for. So that's really helpful.
Yeah, and we're just getting into the how do we get our what they call SDIPs or system delivery plans in the first quarter with providers. As yes, we've had contract meetings, but how do we strengthen that, and how do we start to get into that holding to account piece in that contract arrangement?
And will this change our sort of standard of scrutiny of providers? Because I'm assuming as strategic commissioners, then, if they don't achieve the things we've commissioned them to achieve, will there be inbuilt penalties around that, or is that contractual? Or not, as the case may be, I don't
think there's inbuilt financial penalties. What you can, there are standards in the national contract where you can ask for improvement plans, and you can ask them to deliver against those improvement plans, and you can, at the very last resort, you can withhold financials, but you have to go through a number of steps before then.
Okay, but will those steps change in the new operating model, a new way of working, or will they stay as they are right now? I mean, I know that's probably a question you can't answer, but
I think we're already having that. So the planning group has continued as part of its work in transitioning, and Lee and we haven't clearly, I've just walked back in the building this morning, but Lee was looking at how do we make sure we've got the financials locked down. Some of that is we have to do this. Some of it is about how we put arrangements in around that. And then it's how do we get the wider contract standards complete within the first quarter. And that's about the wider, how do we do quality, how do we do operational performance, and how do we do that holding to account for we spend money with these people and we should get good value.
Move on to quality, David, Kathy.
So from a report, I haven't got anything to pull out by exception, but just picking up Kevin's point, I guess there are a number of documents we're still expecting to be published, so national quality strategy and modern service frameworks that I think will steer how we report back to the board, given what the role of the ICB will be. So I'm happy to take any questions. Kathy, come in on her quality.
I'm just going to add a couple of bits. So I think that point that David makes is really important, but also linking back into we have other levers other than just financial levers that we need to make sure that we're sort of mapping in, and also for me some kind of gaps around some of the things that we are accountable for as an ICB, so safeguarding, CHC. I think there is an opportunity to not just cost of CHC, but actually what does our provision look like with weights, etc. I think there is an opportunity to work that into what we should be seeing at board level as we go forwards. I just kind of wanted to give a bit of a shout out to the LMNS team and some of our voluntary services partners that ran an excellent event last week for us to really kind of get into the women's and significant others voice space, actually, that we're into some of the groups we really do not hear from. Really proud event that was held last week, commissioned through a community partnership approach, and we'll be doing some formal evaluation around that and thinking about then how does that support us as a commissioning organisation as we move forward. So lots of provider representation there, which I think was very helpful, but we need to go into the space of hearing that from a commissioning perspective.
Thank you. Thank you, Sarah, thank you. Item 11, update on the South Yorkshire Health and Growth Accelerator. Nicola, nice to see you. You can introduce it to Christine.
Well, I'm going to do half the presentation.
Oh, geez. You're not doing it all, Nicola.
So thank you, Chair. We're really pleased to be able to present an update on where we are on the South Yorkshire Health and Growth Accelerator. I think this is the first time we've done anything at this level of detail with the board. So if you just bear with me, I'm just going to give you remind you some of this sort of background to this. If you could move on to the next slide, please. So this work, we are one of 3 accelerator sites in the country. So the other 2 are West Yorkshire, North East and North Cumbria. And in South Yorkshire, we deliver this programme as part of an overarching programme of work called Pathways to Work, and we've spoken about Pathways to Work before, obviously born in Barnsley, and then adopted by South Yorkshire, where we are trying to support our working age population to be able to be in work. And the Health and Growth Accelerator sits as part of that, so you can still sort of see the governance of that. We also have an economic inactivity trailblazer, so we work very closely with colleagues at Simca who are leading on that. And there are also lots of other programmes, but key ones that we've flagged there, like Connect to Work and Work Well. And by the way, the ICB is also the responsible person. I am the SRA for Work Well as well, as a deliberate policy position from DWPs to reap those sorts of funding through an ICB to try and join these worlds together. So if we could just move on to the next slide, please. So what is the Health and Growth Accelerator? Well, the Health and Growth Accelerator was designed to try and support those people who are struggling to stay in work or to prevent them from becoming economically inactive. And we were asked to try and focus on preventing 950 people in South Yorkshire in that respect. We use population health, broad theoretical models to try and understand where our cohorts might be, and we landed on 3 cohorts. Those people who are presenting with mental health or MSK conditions that have repeated fit notes for that. We have another target cohort of children and people, and Nick will speak to that cohort shortly. And we also wanted to focus on supporting employers in respect of occupational health and wellbeing resources, particularly small and medium-sized enterprises. So if we could just move on, please. Next slide is busy, and hopefully you've got them all in your pack, but it does show what the accelerator we have stood up over year 1, and we were doing this from a standing start largely. So please don't underestimate the amount of work this has taken. But you can see there that we have an identification and referral part, an assessment and triage part, we have a number of interventions, and then we have another area where we're signposting. And I'll just dip into that in a bit more detail very quickly. If we could just move on, and again, please. You've seen this slide before. We talked about this at the annual general meeting a couple of years ago. This is just a broad estimate of the population needs in this respect. But if we could just move on to the next slide, please. We have developed this model using population health management. And my colleague Lisa Kell, who's the Director of Population Health Commissioning, has been an absolute key director lead in this area. She isn't here to be able to deliver this, but has very much contributed to the development of this and leadership across year 1. But you can see there that we've had the benefit of some ring-fence funding. So whilst ever we've had a situation where we've had real challenges, we've had the benefit of having ring-fence funding, and therefore we've had the benefit of being able to test out what strategic commissioning might be right from the beginning. So I do appreciate we've had that luxury in this space. But we've used, in terms of identifying our cohort, we used the Population Health Management Eclipse search. That enabled us to identify people with those repeated fit notes in that cohort 1, so this is cohort 1. We then commissioned and worked with 33 GP practices across year 1 who undertook a clinical review of those to make sure that they were clinically appropriate to go forward into our navigation hub. And then we moved those people into a hub where they had a holistic assessment by a coach. So this was about people. I don't know if you remember when I was talking about Health and Growth Accelerator, it's about people, not conditions. And it's about health, not illness. Do you know what I mean? So we're just trying to make it around really person-centred. Those people in the hub, when they've done the holistic assessment, have access to an AI service finder, which is something that we have developed in-house, which scrapes the intranet for interventions that may be available, but also includes our own interventions that we've stood up. And I'll go on to the interventions shortly. We have a range of about 60, 70 interventions. Some of those are existing. You see them in your packet on the back page, where we bought additional capacity. Some of those are brand new. They cover a large amount of voluntary community social enterprise delivery, because trust is a key issue with this cohort. The next slide is really interesting. We are starting to build an understanding of the needs of the people through this process. You can see there, of the numbers of people, most people are aged between 20 and 44, so it looks like our population health search is pulling out the right people from a sort of working age perspective. Most people are in the most deprived areas, which is interesting, and most people have been off work now for 1 to 3 months, which is quite a critical time period. So you can just see that. So we are starting to understand the needs of those people. I'm not going to talk about the next slide, children and young people, because Nick's going to talk about that. But just finally, cohort 3, which is our priority 3, around occupational health support. I just want to draw your attention to the work we've done. If you can just move on a few more slides. Yeah. So it doesn't matter how much time and effort we invest in supporting people with health conditions to stay in work if the employer is not in the right space to provide that support and or to keep people in work. So we have invested and worked with around 80 employers across South Yorkshire. We are providing referrals from their occupational health to our services that we've set up, digital MSK services, our mental health solution, physiotherapy, talking therapists, which we already commissioned, so don't worry, we haven't gone and recommissioned talking therapists. We have undertaken workplace health checks, about 30 businesses have participated, 600 people are receiving health checks, and around 200 people have been referred to their GP as a result of that. So we've done train the trainer. We have 2 of our main occupational health service providers in South Yorkshire providing this, plus our Sheffield Occupational Health Advisory Service doing train the trainer. And we are working with Barnsley on their test and learn in this space. So that's a very quick canter through this. I'm going to pass to Nick in a minute. With Year 2 funding, we do have Year 2 funding. It is not as much. We still have another target to meet. So all of the information around that is in the pack. But we are spent most of Year 1, I would say at least half of it, commissioning, contracting, understanding, setting those things up, working with place colleagues, working across South Yorkshire to get this set up. We've not had much time in delivery to get the evaluation. The whole point of this was to evaluate what is working and what isn't working. So having the Year 2 funding will enable us to continue to commission. We're not planning to do loads of different things. We want to carry on with what we've set out so that we can get the evaluation and start to learn from that. But I'm going to pass to Nick, who's going to just talk about...
Before we just gave you
just a very quick question about deprivation, because we actively targeted the practices who were looking after the most deprived communities. So it's good to see that reflected, because that was something we picked 33 practices out of the 169. So it's only to make that point.
Yeah, thanks.
Nicola.
Brilliant, thank you. So I'm Nicola, I'm the Children and Youth Alliance Programme Director. And I'm going to give you a brief update on the 16 to 24-year-olds Health and Growth Peer Connector service that we've developed. 3 key messages I would say around it is that we built it on feedback that we already knew and had from young people about what they were struggling with and what wasn't working well. We've developed it in partnership with 7 voluntary community sector provider organisations who we know are experts when they're working alongside young people. And so far, it's making a difference. And we haven't got a lot of evaluation information, but we've got a lot of feedback from young people who've been part of the service to date. So young people have been experiencing feeling overwhelmed, really struggling to engage and navigate either staying in education. So part of what we were doing is thinking about working alongside colleges, DWP youth hubs, to understand the need and then think about what we can do in that space to think about the health aspect of that. So talking about mental health, low to moderate mental health difficulties, and neurodiversity where it was getting in the way of young people being able to continue in college or in education. And so alongside that, we've had other voluntary community sectors who've been working alongside young people to understand how we communicate, how best to engage. Then it goes way back to that part. You mentioned trust, so it's building trusted relationships, signposting, thinking about hand-holding onto services, making sure that young people feel they're connected to what it is that they would like to do that might support their confidence and mental health. It's probably a step before thinking about how then to get into employment or what type of work young people would like to do. And every aspect of the pieces of work are something that builds the confidence in. So being part of the campaign to think about how they communicate and engage has all been part of the intervention to support young people. So young people have said that they want the peer connector model to be something that says it's with you your way. So they've described that as how they want to be engaged. They do not want transactional models, they want relationship models, and they want to be able to build that trust with people. So you'll see, I'm sure that's one of the numbers, yeah. So in terms of mobilisation, we mobilised end of December time, so between December and the end of March, there's been 120 referrals across South Yorkshire. The majority of young people have engaged, maybe for short periods of time or longer depending. There have been very few that haven't done that, which is fantastic. And what we're thinking about doing for Year 2 is working on a model where we have the providers hosting, coordinating the model going forward, so a hosted approach, coordinated approach with the voluntary community sector organisations collectively together. What we want to do is have a real sustainable model of service delivery going forward. We're continuing to work around the comms engagement, and the other aspect is around peer evaluation, so young people talking to young people about their experience, what's working for them, and that helps to weave into what we're doing going forward. So still test and learning, but tweaking as we go.
Yes, so that's really helpful.
Do you have a 1 minute video?
Was it? I don't think it's on.
Oh, is it not?
That's where it's really not inside. Which, yeah.
We've circulated the book.
Yeah.
That'd be really
So
helpful.
there's
Any-
2 videos, they're very
Any questions? Shahida, then Graham.
I think this is an absolutely brilliant piece of work. Am I right in thinking we've got year 2 funding, but we don't know about any money post that? So I think the question for me is then, yeah, and I think this is about sort of learning and evaluation. And if we're doing this shift towards strategic commissioning, how intentional we are going to be in terms of taking this really, really valuable learning and what it's telling us as a system and going, right, we know this works because this is what the evidence is telling us. And in the past, we've been, we've had projects come and go, we've had pilots come and go and evaluations come and go. And even when we know something works really well, we'll go, oh, but there isn't enough money in the system to carry it on. So for me, I suppose the question in my mind is, how are we going to be, back to Emma's point about being brave and courageous and going, how intentional are we going to be about this? But I think this isn't an ICB question, it's a system question, which says, if we've done this collectively and we know it works, and it's having an impact for our young people and at some of our most deprived communities, how do we retain that very, very clear intentional decision making that says, we're going to continue with this, notwithstanding that there may be, or there might not be any further central monies or whatever. I appreciate that might mean that we're having to look at the pound that we spend, because that might mean difficult decisions around stopping something else in order to do this. I don't know, but I just don't want to lose what we've done this so many times in the past. We learn, we evaluate, and then we park it to the side because we think it's potentially too expensive or whatever the issue might be.
Christine, you want to come back?
Yeah, please. So,
I'll come to you, Greg, sorry.
So yes, we cannot rely on additional programmatic funding for this. And I think there's a couple of things that I think will help us sustain this. One is where can help us identify as one of our core commissioning portfolio areas in the new organisation. So somebody in that structure will have the portfolio that includes work and health. The reason, so I think that will bring it in. What exists in that pot to be able to commission is the other question. But we also commission MSK services, we also commission mental health services, we also commission services to children and young people. Do you know what I mean? There are things that we're doing already that potentially, if we learn from the Growth Accelerator what works, could then inform how we use the funding we already have. The second thing is, this exists as part of Pathways to Work, and I think that's what will help sustain it. This is a commitment across South Yorkshire to bring together employment, skills and health into the same space. And we have a shared governance arrangement that supports that at the moment. So those are two things that I think could help us sustain. And as Nick says, in our development of this, we've always had an eye to the end of this programme.
Great.
Cheers. Stellar example of doing the determinants of health really, really well. Take that as read. 4 quick thoughts, and don't need to come back on all of them by all means, but just the joint governance, I'd be really interested in kind of how that's working out and lessons for other programmes. Lots and lots of positive feedback on the very micro neighbourhood and relational model of commissioning, I think, but don't know. It's a question for evaluation. That's one of the reasons that sets South Yorkshire probably ahead of the pack in that space. So I kind of cement that in. Year 2 funding, given the pain, servitude and time frame and asking expectations, I'd just say carry on. Rather than kind of setting up a new set of stuff. And priority 3, here a lot of love for the train the trainer thing. I'd personally be a lot pushier with employers in getting away from the helping individuals into the toxic working environment, kind of, here's a bowl of bananas and employee assistance program versus toxic working environments and stress type of territory. And I think there's something to be pushy on in that space.
Thanks.
Okay, really helpful, really interesting work. Sorry, do you want to come in?
I guess the critical thing for year 2 is just going to be the evaluation strand, isn't it? Okay. And it inevitably, Shahida, gets you into this whole total place pilot. The benefits accrue plurally for the machinery of the state. And what does it mean for a health commissioner of this sort of work? Yeah. So doomsday scenario is you can evidence all these benefits, but they don't accrue and a rate of return for the NHS budget at a rate that you need, when the benefits for this are so multi-faceted and diffuse around the state spend. So I think it's why the evaluation becomes so important.
Thank you. After the evaluation will be critical. Christine Nicola, thank you, nice to see you. Agenda item 12, I'll pick up quickly the ICB running cost reductions. We've already had a discussion in private board. Don't propose to have one now. We'll have communications with our staff tomorrow and then communications beyond, and I'll leave that at that, if that's okay. Item 13, the change in the constitution. Do you want to just briefly?
Yeah, thanks, Chair.
We've had discussions previously.
Yeah, absolutely. So this paper presents to the board proposed changes to the ICB constitution. It reflects discussion and changes that have taken place over multiple months, and including board development sessions, and reflects the changes initiated by the Model ICB Blueprint and the Organisational Change Programme. And subject to board approval today, or board support today, I will submit this constitution to NHS England for their consideration and approval, with a view to it being enacted on the 1st of July and adopted at the 1st of July board.
Thank you. Sheila.
Does this take into account the potential for the Health Commissioner? Will that have implications for us?
Has
no bearing on that.
Okay, people comfortable, so just asking for your support today, it actually has to be approved by NHS England, not by ourselves. Mark, thank you. Financial delivery report, Lee, 14.
I think I can be relatively brief here. I am simultaneously disappointed but pleased, such is the duality of the role of NHS finance. I'm simultaneously disappointed but pleased to report we've missed our plan as an ICB and an integrated care system, but we hit our forecast change protocol forecast that we did at month 9. So where that leaves us as an ICB is we have a year-to-date deficit of 48.9 million, which is 48.9
last
million
year to date,
behind the plan. 25-26. Sorry, we haven't delivered 26-27.
That's why I was slightly.
We're good, but not that good. So in terms of the old year, 25-26, we have delivered a deficit of 48.9 million. We didn't receive some additional deficit support funding, so we have a net variance before deficit support funding of 39.8 million. We've had to make a large provision for and accrual for redundancies in our year-end position, which will fund the organisational change programme in 26-27. But there's a high degree of certainty in those costs, therefore we've accrued them. Very positive story is we did deliver our overall efficiency target as an ICB of 97 million. What we couldn't do, however, is contain the pressures we had in year around referral to treat activity for both mental and physical illness, and we certainly couldn't live within the all-age continuing care national growth assumptions. So a big focus of the work for 26-27 is how do we try and compress the costs associated with that referral to treat activity effectively and safely, and how we can work differently in that all-age continuing care space. So obviously all of these numbers are now subject to external audit, who are now in the building, physically, I think, as well as virtually, reviewing our position. So we'll update formally once we've got beyond the external audit process about this being the confirmed position of the ICB and then system.
Your question, that's consistent with conversation we've had over the last 3 or 4 months, if I remember right.
Yep.
Chair, just with saying I will sign off formally on July 1st.
Corporate insurance report, Mark?
Thanks, Chair. I take the report as read. All I would draw out are there are 3 policies for ratification that have been published on the ICB's internet site, and there is 1 terms of reference for the Remuneration Committee, which has been subject to its annual review, which is presented to the board for approval. That's it.
People comfortable with that? Thank you. We've then got items for information, minutes. Anyone want to pick anything up on that? No, thank you. That's the end of the meeting. Thank you very much for your time.
Sorry, Chair. Kevin, sorry, she last meeting, we've got to say.
The
chairman's out there.
Nice try.
And I know that one of the things you're very proud of is finishing a meeting on time.
Yeah.
So this gives me really perverse pleasure. Going over not allowing you to do that. You did remind us at the beginning of the meeting this is your last public meeting, which sort of caught me by surprise, even though I've known about it for some